All right, good afternoon, everyone. We appreciate you taking time out of your busy schedule to join us for this webinar. My name is Sarah Bowman with TBD Solutions, and I'm joined by Travis.
Good afternoon.
And Josh.
Hi, everybody.
Today, you will not be hearing Josh quite as much as usual, but he is here, and he will be sharing at times during the webinar, so we're glad that he was able to join us. Today we're going to talk about redesigning processes to support organizational learning. So we're going to do a lot of talking about this concept of a learning health.
The broadcast is now starting. All attendees are in listen-only mode.
The continually changing landscape of healthcare today provides us with a great opportunity. We have access to more data now than ever before, and this access comes with responsibility. The responsibility to learn from all of that process is what we're going to focus on. System that consistently provides high services and improves. So the first thing we're going to do today is actually do a little bit of traveling back in time, chemistry or biology. I kind of my science teacher for most of my science classes was Mrs. Lufgren. Travis, who was your science teacher in high school?
Mr. Clark.
Mr. Clark, okay. So think back to science class. I know Travis and I both had lab coats that we got to wear at our schools. Hopefully you had lab coats at your school as well. You have those like high lab tables with the black mural. We had wheelie lab chairs that the gentleman was getting in trouble with. And there was all sorts of fun equipment to play with in science lab. Maybe you were one of those overachievers that entered the science fair and created a poster session with all the steps of the scientific method for your particular experiment. Now, during our time together today, I want you to keep that high school science class mentality. No, I don't want you to throw spit wads at each other or pass notes back and forth, but I would like you to simply remember what learning is all about. If you remember one thing from today, please remember that a learning health system simply means to follow the scientific method. Identify a problem or a question. What is it that you really want to learn? You know, when you think about your team or the people you serve, what is it you want to know or that you need to know? What are all the sources of information that you can tap into to research that issue? There's no checklist, sorry if you were hoping for the checklist, there's no checklist of the 10 steps to creating a learning health system. But today we will look at the basic characteristics of a learning health system. We'll go over some of the challenges in the healthcare field today, some of the opportunities that those challenges bring us, and then we'll wrap up with some ideas of next steps and some ways that you can really look at your processes within your organization to make some changes to become a learning system. So this picture here, basically just showing you the basic elements of a learning health system. A learning health system generates and uses real-time knowledge to improve outcomes. It engages patients, clinicians, and communities. And I like the fact that it talks about engaging clinicians and communities. There's a lot of talk out there, at least in the behavioral health world, about engaging patients. But for a system to be effective, we really have to engage all of those groups. The system needs to be doing all of that while providing high-value care and finding ways to reward that high-value care, which we'll talk about incentives later. And all of those combined actually creates a new culture of care. Unfortunately, healthcare in America today is not a thriving health learning system. It's actually in more of a disease state, and we're going to call that disease the failure to learn disease. And some of the symptoms of this disease are lack of learning routinely or systemically. It's not learning at scale, so even if there's a pocket of improvement or a best practice somewhere, It doesn't necessarily mean that it transfers from one organization to another or one branch of healthcare to another branch. It's so alarming that we have this shockingly large gap of 17 years between the time knowledge is generated and when we apply it. You know, in worst case scenarios, that's people dying in that time span, or just having a poor quality of life. In healthcare in general, there's been an explosion of biomedical and clinical knowledge. I mean, think about in our world, in the CMH world, evidence-based practices have really exploded in the last few years. There are so many EBPs out there now that if an agency gets too aggressive in its desire to implement multiple EBPs at once, there really can be harmful results. Your providers can get burned out and feel pulled in multiple directions. You can end up having low fidelity to all of those best practices. And unfortunately, in your zest to embrace evidence-based practices, you can lose sight of the patient's perspective on care and their care experience. You just get into that mentality of research says that this works for this population and you have this disorder, so thus you will get this treatment and you will get better. We need to remember to check in with folks, right, and see what their thoughts are and if it is meeting their needs.
So Sarah, it sounds like that good intentions then aren't enough. That just to have a desire to implement an evidence-based practice to help the people that you serve, it doesn't necessarily mean that that's what's going to be the most helpful for them, or that that's good enough just to do that action.
Absolutely. We need to look at what resources and infrastructure, what support is required when we want to take some new, whether it's an evidence-based practice or just some other new business or clinical practice, we need to be thoughtful about the implementation. Now, the trick is, unfortunately, in our field, we're often so slow in training providers, in adjusting payment methodology, in adopting these new practices, that's where we get that 17-year lag, right? So we need to find a balance between being flexible and responsive and adaptive, but not too fast that harm is caused and not too slow that change never really occurs. And Travis, now you're going to talk to us a little bit more about some of the challenges in the healthcare field today.
That's right. So it's easy for us to feel sometimes that our problems are unique to our system, but in fact other industries are addressing some of these problems pretty effectively. And so we're going to talk about some of the challenges that we face and where healthcare falls short, but then also what some of these industries are doing to address very similar problems. So the first one pertains to information technology. So almost half of patients report that information necessary to their care was not available when needed. Imagine going to your computer and going to type in like a website or going to search for information that you needed, and the website was down, or the W key was missing from your computer, and you needed to type in, obviously, 3 W's to get started on your website. Maybe your browser wasn't very intuitive, and so having that missing link when you need it is when it matters the most, not when you don't need it. 25% of patients said that their healthcare provider has had to reorder tests to have accurate information for a diagnosis. So having to do things over, not having access to the information that they needed. Maybe the people you serve have had to go to different ERs for testing, and the second ER a month later doesn't have access to the first ER's lab results. And so then they have to run the tests again, and there's cost involved, and there's, the two systems don't share because the hospitals aren't in the same health system. So that's one example. Another one has to do with building systems. So over 200 additional doctors are involved in treating the average primary care physician's Medicare patients. Okay? So imagine if you're a doctor and for all the patients that you work with, there are 200 other doctors that you have to talk to and interface with, and they could be as diverse as the people that you serve. You know, they could be from far away, they could be old, young, have, you know, different ideas in their practice of how to do things. Also, 180 activities are managed by clinicians in intensive care units per patient per day. So we talk about systems, like there's a lot every time a person you know, is admitted and lays down or sits down in bed, everything that has to happen there. Let's talk about safety for a minute. Hospitals, there's a report that says that 1/3 of hospitalized patients are harmed during their stay in one way or another. So this, you know, this method or this Hippocratic oath of, you know, do no harm, like that's not being fulfilled in these places. And also 1/5 of Medicare patients are re-hospitalized within 30 days. So if you've got a, you know, like a hallway or an ER and there's 5 Medicare patients sitting next to each other, you know, you'd hope that they could all get their issues addressed so that they wouldn't have to come back very often. But the truth is one of them is going to have to come back. As far as transparency, 85% of people have not been informed by comparative quality information about their health care. So they haven't been told like what the better choice is or what their options are. Sometimes there's just not the depth that's needed to make a quality decision, and so the information given is short, and so then the quality of the decision is compromised. And understanding the cost of care is also very difficult, and so when you have to sort through a bunch of medical bills and look through brochures or pamphlets and say, wait, how much did this cost, and who told me that, and you know, where is that located? Is it on their website? You know, it's not necessarily. And we'll talk about a parallel there that is so different in other industries. Teamwork and communication is also an issue. Half of patients with a chronic condition report that information about their diagnosis and treatment was not available when needed. So similar to the information technology, when somebody needed to know about a person with you know, comorbid conditions, that information wasn't there. A lot of people think that the healthcare system is broken in our country. As a matter of fact, 1/3 of adults think that way. So if there's not a lot of confidence there, that's going to contribute to believing that they're not going to get the help that they need. Partnering, less than half of patients receive clear information on the benefits and trade-offs of treatment for their condition. So doctors or providers just might get into a system where they say, I know this works, I don't have to explain it. There's not like a shared decision-making experience. It's just, this is your condition, this is how we're going to treat it. Do you have any questions? And sometimes people say, do you have any questions, when they mean, I'm done talking. So I hope you don't have any questions. And then for waste, a 1/3 of the healthcare expenditures that we have don't improve health. And that's an estimated cost of $750 billion. So imagine just how much more we could be doing if everything that was done was effective, you know, was meaningful, was bringing some people to a better place instead of homeostasis or making things worse. So now we'll talk about the other side, about some of these organizations or these industries that are really laying some great foundations or have done incredible work to improve their own systems. The first one with information technology is banking. So banks have made a lot of improvements in the last 10 to 20 years in this age to improve their technology, to put information about money, about a person's money, right at their fingertips. You think about you know, online banking when you're logging in, mortgage payment, sending out a check, doing bill pay, even now being able to take a picture of a check and deposit it. Everything is at people's fingertips, like immediately. Building systems, it's extremely complex when they're working in a global market. We use Toyota as an example. So the average turnover from concept to production is 2 years for a car. So right now it's 2015, and so right now most car companies are designing their car that's 2 years out because that's how long it's going to take to make. Toyota has been able to cut that amount in half, and they have 1 year from concept to production. So right now Toyota is working on their 2016 cars, while other car companies are working on their 2017 cars. So just cutting out, just making things more efficient and being able to manage a lot of complexities in their systems.
And is that worth comparing, Travis, to like the 17 years of lag?
Yes,
in
it is.
adoption
I'm glad you said that.
We heard about the initial figures that Sarah was presenting of 17 years between research and actual implementation of services. It's helpful to think about this sort of like really quick turnaround and development time that a car company has been implementing because of the need for that product. And I'm sure that anybody listening today it would be hard for anybody to argue that the products of healthcare and of behavioral healthcare, like the actual improved outcomes that those things can bring, are not just as needed as cars.
Yeah, yeah. And so if you think about having that kind of lag in the automobile industry, if we needed to cut out, greenhouse gases or emissions within 5 years, and somebody came up with an idea and I said, well, the good news is I got an idea. The bad news is it's going to be 20 years. Well, we're going to be out of gas by then, if we don't make the change. So the implications would be so huge, and they are huge for the healthcare system too. We just don't. Maybe we just take it for granted a little bit more than we would in, if it was like a world shortage of like a supply or something like that.
Mm-hmm.
So when we think about safety, the aviation industry is an example of how they have just pioneered great safety practices. They understand mistakes or accidents that have happened. They learn from past performances. They make adjustments. They do everything they can to ensure a safe flight. If you've ever traveled in a plane and you've been delayed because they have to de-ice the wings, which happens in Michigan, of course, or there's some sort of mechanical problem, they understand how important it is for people to travel safe. And when there's accidents, they're looking in the black boxes and they're trying to figure out and put together what exactly happened, and they take it very seriously. It's very rare that a plane accident happens and they don't know why. So when we talk about transparency in a different industry, you think about if you shop for an appliance like a washing machine or a microwave, or if you go to book a hotel, you can compare the prices and look at performances or reviews of performance for those items online, and it's at your fingertips. There's websites that are dedicated to this, like hotels.com or other kind of conglomerate websites. Kayak, they bring together prices of things and they make it easy for you to compare. Imagine if that was the same in healthcare. Imagine if you could go and look up like a heart surgery or a liver transplant, and you could compare different hospitals and doctors and their performance. You can do that on a very small scale right now, but imagine if you could do it easily. Teamwork and communication, back to like the aviation industry. There's mission control teams that are working around the clock with flight patterns and communicating to say, these flights are going transcontinental, from Phoenix to New York or from Boston to LA. I mean, if you think about it, there's planes that are going overhead all the time. Our office is actually by an airport, so we know what planes are going overhead. We can tell you in about 5 minutes there might be another one if you hear a big whoosh come over our conversation. But that's a complex system, and that requires a ton of communication to be able to make sure that works. As far as partnering, think about what it takes to build a house. Think about general contractors or to build a new building. people don't all know how to do everything, but they work together. The electricians, the plumbers, the general contractors, the people who are laying the foundation, they all have to work together to build a product, and they have to do it well and consistently. Otherwise, people won't buy their houses because they'll fall apart. And lastly, assembly lines do a lot to decrease waste. So back to the example with Toyota, they've been instrumental in these practices of process improvement, using Lean, Six Sigma, other methods to reduce waste in product lines, to not have, to use the resources of humans, to not just relegate them to menial tasks, but to actually have their input included and involved in processes. All those things can make a really substantial difference. And you think about back to the waste that we have in healthcare, what would it look like if we were doing it really well and if everything was really tight in its operations?
So although those statistics about the challenges and the concerns are pretty startling, it's pretty exciting to think about the opportunities that other industries have pursued and what we can learn from them. So thank you for sharing that with us, Travis. Now, to recap what we saw on an earlier slide, I just want to remind you that a continuously learning health system must include these 4 characteristics, and we're actually going to kind of dive into each one of these in a little more detail and take a closer look at each one. So under science and informatics, it's critical that you all have real-time access to knowledge. So, for example, if you're currently using a that transfer notice at a local hospital, that's a great example. That their person went to the you yesterday on and care. Would be your facility. For example, for the sits with the assessor, completes the assessment together. At the end of that, some sort of functional assessment tool like a locus, information, the score of the functional assessment they will eligible for, this might be recommended, and that assessor can have informed discussion with consumer right at that time to make some decisions on their care. Now, no, that's not a chat. In case you can hear that. Take informed gathered with the input of the consumer. If you're kind of more using a more old school approach and maybe taking handwritten notes during the assessment and then typing it up a few days later, or doing the locus or CAFIS or DLA after the fact, remembering what the person said, now not only might that reduce the how accurate the information is you're putting in due to the lag time, but you won't be able to have that discussion with the consumer or patient right at that time and make some decisions and move their care forward. There's going to be a lag. So as much as possible, do things where you are either getting or creating real-time access to that information. One of the struggles in our field, an example where we don't have real-time access, is inpatient billing or adjudication of inpatient claims. Those of you involved in that process know that it can often take months to kind of sort out that mess. So if you're an access manager using your inpatient billing information to watch for trends or analyzing your utilization, you're going to be handicapped by a few months of lag there. So you're going to want to find another source for information to monitor your inpatient utilization that is real time so that you can act upon it more quickly. The digital capture of the care experience is pretty critical as well. In the behavioral health world, we're really good at documenting, right? We go to school to learn how to write these really lengthy, detailed assessments and progress notes. However, most of those documents that we create don't result in much data, at least data that can be quickly utilized. So if in your electronic medical record, let's say in your progress note or in your assessments, you have lots of long narrative sections, it's going to be really time-consuming to pull data that can be acted upon out of those. Or if you're still using documents, hard copy documents, and then just scanning them into your record, that's not going to get you real-time generation and application of data, which is what a learning health system needs to be able to learn from itself and make changes in real time. The patient-clinician relationship, I think that's an easy one for us to all agree is super important. Having patients that are engaged and activated, that feel empowered. I think the behavioral health world is probably a bit farther ahead than the rest of healthcare in this area, but we still have opportunity for growth. Person-centered planning is not simply agreeing to every patient request, right? So we don't just have to go along with everything the patient requests blindly. We need to remember that patients are one of the most underutilized resources in healthcare today. There are significant lessons that we can learn from listening to the patient's perspective of their health and their experience of care. So rather than blindly just agreeing to every patient request, we need to have meaningful discussions between the provider and patient, truly exploring the evidence regarding different treatment options, the risk of different treatment options, pulling together all sources of information so the consumer can really make an informed choice about care. Josh and I have talked about this before, and I wonder, Josh, if you would be willing to share with us, you know, what might a PCP meeting, a primary care, or I'm sorry, not that PCP, a person-centered planning meeting look like within a learning health system?
Yeah, and I will try not to get on too big or at least long of a soapbox about this, but I think this is a really helpful question because it helps people to think about how do all of the different pieces and parts that you've actually just walked through all sort of converge on one of the critical places where decisions get made in the behavioral healthcare system. So in a PCP meeting, essentially you're sort of looking at presumably the assessed needs of a person and then also sort of running that through the person themselves to see what does the person actually want to work on, right? And what happens a lot of times is that it ends up being just a really sort of open field of, hey, here's a whole bunch of possibilities, but given all of those possibilities without any additional information, a lot of times people end up just sort of choosing the same things or being overwhelmed by, you know, the potential options that they're facing, right? And in some ways, having a really carefully architectured choice that we're presenting to people can actually lead to better decisions and more engagement in the decisions that they make. So Travis was saying before, like there's a number of different fields that are informing the way that healthcare is moving forward. There's actually an entire field called choice architecture, which is a field of behavioral economics, which looks at how to structure decisions to get the optimal outcome from decisions. In a place that this is being applied in healthcare right now and in behavioral healthcare is in something called structured decision making, where like the Mayo Clinic has put a lot of resource into, and SAMHSA has developed some resources around this as well, looking at how do we structure really key decisions in the process of care where we say, all right, this is the need that you have, this is what you want for your life, and here are really the options that the evidence says would best help you to reach that goal. And you're really drawing from existing evidence and trying to bridge that 17-year gap in a way that a person is really engaged with, right? So it's not just data sort of crunching numbers and outputting, here is the service that you will receive. It's actually giving the person an informed choice that they can move forward with.
Thanks, Josh. So to further discuss how to empower or activate or engage patients or consumers, we need to remember there's a great potential for the use of technology to capture patients' healthcare data. Now, Facebook might not be the answer, but there are a growing number of other social networking sites specific to chronic conditions or certain populations. For example, there's one site called The Body for HIV patients. There's a site, Patients Like Me, for persons with chronic medical conditions. And folks actually use these sites to track and report various health measures, maybe their blood pressure, blood glucose ratings. They share their progress and their challenges with others on the site. The Institute of Medicine has a discussion paper posted on a survey of the use of these sites. Patients reported numerous benefits, including developing a stronger understanding of their medical conditions, feeling more in control of their disease management, and actually improved compliance with treatment. The study found that overall, basically all of these stats on the screen here are showing that patients are comfortable with their health data being shared to improve care and help others. Now, there's a lot of work that needs to be done to be able to harness the power of the data that's captured in these social networking sites to actually inform a system of care, whether it be primary care or emergency care. So there's a lot of infrastructure that needs to be developed there, but those are the questions that we need to be asking. Those are the things, the direction that we need to head to think about how we can be tapping into those resources to better engage patients. And I just wanted to highlight a website that some of you might already be aware of that CMHs in Michigan, some are using, and that's the mystrength.com. If you haven't heard of it, go ahead and Google it. But some CMHs in Michigan are offering this high-tech resource to patients to support them in the recovery process. And we, again, as a learning health system, we all want to be exploring how our organizations can utilize these different technology applications to activate patients. Incentives. So everything comes down to money, right? Money is pretty important. Whether we want it to be or not, it is. And I'm not going to spend a lot of time on this piece. It could be its own series of webinars. But I did at least want to point out that another key characteristic of a learning health system is providing incentives or value-based care. I encourage you to check out some of the recent developments in New York. Over the next 5 years, New York has a goal of making 80 to 90% of its Medicaid payments through alternative payment models that include shared risk tied to cost savings and quality measures. So how we're paid often kind of forms how we provide service. And unfortunately, for the majority of healthcare today that's fee-for-service, it results in volume and care duplication. So there's a lot of work out there being done on these value-based care movements, looking at rewarding value and care coordination. So I did put a link here for a really comprehensive write-up of what they're doing in New York. And if you Google it, you'll find those documents. You'll also find some work. Medicare is also advancing very much in the value-based care arena.
So we want to spend a little bit of time talking about transparency. So a question I want to ask to you is your organization's data accessible to everyone? Or who is it accessible to? And do you understand any of the reasons behind that? Part of being open to this process of data is an acceptance of what data brings, what the implications are, whether positive or negative, or what types of things that they indicate, because the data is meant to help us to get better. And when we're transparent, when we strive towards transparency, and others do, we can learn from one another how to best use data. So to give an example, rates of compliance with pneumonia care measures increased from 72% to 95% the Joint Commission a few years ago. And the primary reason, I believe, Sarah, was that it was because they were sharing data. They were sharing practices.
Yeah, it just boiled down to, as we've talked before, Travis, we know that simply tracking something can impact that behavior for folks, trying to lose weight. Simply keeping a food journal will impact their food choices. But then, and gosh, I kind of hesitate to think about sharing my food journal with you all, but in the behavioral health world, if we are sharing, as they did in the primary care world, our rates of compliance with various measures, they just shared how different departments or units or organizations were doing with their compliance with pneumonia care, and that kind of holds you accountable. It's really out there. But you're going to talk about in a minute, the spirit in which that needs to be done is pretty important, or there can be negative impacts.
Right. So three examples that we could use for transparency with data. The first is recidivism. So how often are the people that you serve coming back to the emergency room, psychiatric hospital, the medical hospital? What are the number of days from the time a person is referred to services until they complete an intake and they're open for services? And what is the length of stay for a person either in services, in a crisis home, in a hospital? These are all ways that we learn because we know national averages, and those happen from sharing, and so we know whether to assess our data as good or bad, or to place some sort of value judgment on it. But these are opportunities, just a few examples of opportunities that we can use and that we can share to help to improve what we're doing.
Yeah, I like your idea of recognizing within, think about your role at your organization and the teams that you lead. What are the main points of data that would be helpful in measuring the performance of your team? And then how can you benchmark that? How can you benchmark it to state averages or national averages, or maybe just your regional partners? Or just trend it or benchmark it essentially on yourself of past performance. Oftentimes, some of these things are dictated by the state, and there is transparency because we all have to report at the same frequency, and it ends up in a report that someone may or may not read. But we need to make sure that we're asking the critical questions of what is important, what makes a difference in the care we deliver, how are we performing, let's share how we're performing, and share our progress over time.
Mm-hmm. And so the most important piece around here is the culture that you exist in as it pertains to data and transparency. So are you, a part of a culture that's working together, that's using some of these keys in how you learn together? And so the first one is collaboration. Are you willing to collaborate not just with your peers, the people in your department, but people in other departments, or even people outside of your organization, maybe places that you haven't collaborated with before?
And the collaboration and teamwork that you're going to talk about in a second makes me think of the webinar that Josh did recently on a data culture, and remembering those roles that different people fill, and how you can't just have those roles, but those people need to communicate and need to interact.
Yes, absolutely. Teamwork is another important part of a learning culture, being able to share knowledge together with one another. Adaptability, being able to deal with the changes, and changes happen all the time in our systems, from changes in Medicaid guidelines, changes in what DCH wants to measure, what our own organizations want to measure. Mm-hmm. And really, it's important to ask yourself, how do you define failure, and how do you deal with it? Is failure the end of your organization, or is failure just a mistake? Is it a learning opportunity? How do you conceptualize failure? How do the people on your team conceptualize failure? And how do you turn that into something that is healthy, that can eventually create some good? So when we think about evolution of our teams, I want to ask ourselves, you know, how far have your teams come? Let's say you've been there at your organization for 10 years or 5 years or 20 years. How have things changed in the time that you've been there? Have they been for the good? Have they helped you to become more adaptable? Have they helped you to thrive in the environment that you exist in now? So I'm going to take us back to 1995. Sarah said that we were doing some time travel, so I'm going to piggyback on the time travel
We
here.
need to get into, what is it, the DeLorean?
Yeah,
to
the
get back
DeLorean.
there?
Yep,
okay.
the flux
So
capacitor.
enter the DeLorean.
Yeah, okay, 88 miles per hour. So back in 1995 was the first year that that basically the public was made aware of the internet, that it started to become this system or this entity that people understood. 2 companies were created out of that time, America Online and Prodigy. So for those of you that were signing online back then, like myself, these might be some nostalgic companies. And some people still use dial-up modems, but back then that was the only way you got online. It was this bing, bing, bing. It was this, just doing that brings back good memories for me. But and so these 2 companies came in, and they were the premier providers of services, and so you paid a certain amount a month just to be able to get online, just to use their services, and then you had a certain number of minutes a month. I can't wait to tell my kids about this someday, but you had like 200 minutes a month that you could be online, and then you'd start getting charged by the minute or by the hour after that. So these companies were premier back then. Obviously, they were doing the work. Google actually wasn't even created until 1997. So you think now Google is so prominent that we don't even say search anymore. We say Google. Like, it's become a verb in how we talk about things. These 2 companies, looking where we're at now, they're not very relevant. I mean, America Online has been able to keep a steady following. They're still like a top 5 search engine, but they're not Google or Yahoo or Hotmail or some of these other ways that people use, how they get their email. And so, I don't even know if you could call it a flash in the pan, but just these companies didn't necessarily adapt at the rate that other companies did. Another company that was started in 1995 was Amazon. They sold their first book in 1995, and Amazon is a company that has done some incredible evolution in trying to redefine who they are or to stay relevant. And if you've ever seen any interviews with their CEO, one of the things he says is that Amazon might not be around in 20 years or 50 years. He said, I know how other companies have worked, and it's going to be really hard to exist. And so he's encouraged initiatives to stay relevant. They've got streaming like music now and videos, and they have like grocery shopping services now, and they're constantly trying to either redefine or add value to their customers, and the results are fantastic. And then another thing that came out in 1995 was the DVD. And so if you think about the history of how things were, how video was viewed at home, the VHS had quite a carve out there for a long time, and it was hot. It was a cool thing to have. You think DVDs came out that long ago, and they held their place for 15 to 20 years, but now we've got Blu-rays, and so DVDs are slowly becoming less relevant, and so that makes them cheaper, and now having a VHS player in your house is fairly obsolete, and they go, fewer people have them every year. So all of these products or companies or services, they felt fresh and exciting at the time, but they've had to adapt to remain relevant. And so it's the same for us. We've had to adapt our systems over the last 20 years, and how will we do that for the next 20 to provide quality services to the people that we serve.
Yeah, I think when I'm looking at this sort of like list of companies that's sitting out here, it brings me back to, I think, what Sarah's initial time travel experiment, trip back to science class. And if you look at these companies, a lot of times what happens with companies is that what they're doing is they start making a product and not trying to answer a question, right?
Yeah.
So Amazon is this company that's continually sort of recreated itself by trying to answer a question. And that question is, or at least one of the questions is, how do we get books, how do we get entertainment, how do we get a product to a customer as quickly as possible, right? So like you'll hear about, they're sort of brainstorming about how would we use predictive analytics to predict what product somebody might buy and use drones to deliver that before the person ever clicks on it. Right? I mean, and that's the sort of thinking that's, while it sounds almost like futuristic, it sounds like Terminator 2 or something like that. They're asking the question, what is our purpose, rather than what is the product that we provide, right? And so the healthcare equivalent is something like, is our purpose to provide this HCPCS code? Is our purpose to perform well on this HEDIS measure? Or is our purpose to save people's lives?
Yeah.
And we're finding new ways of doing that, whatever it takes, right? So, and a lot of it really is just sort of the frame and the way that people ask the question and try to define what it is that they do.
Yeah. So it's almost kind of like a product versus purpose kind of question, which to me says it's the why of what you're doing versus the what that you're doing. Are we just delivering case management services? Are we just, or are we serving people? And that can look so many different ways.
Absolutely. The only other point that I wanted to add about the culture and these organizations and our own organizations is that that point you made about failure, I think is so important, Travis, that failure is key, and how we react to failure, how we view failure. I was sharing with you the other day that I had seen a leadership video on YouTube where a CEO of a major technology company was talking about a senior vice president had made a huge error that cost the company millions of dollars, and the vice president had gone in and basically said, okay, I guess you're going to fire me for this error. And the president said, well, no, I just spent like $3 million training you. You learned a tremendous amount from this. And I thought that was just so refreshing to think about, wow, it didn't work. Very cool. We are going to learn a tremendous amount from the fact that this failed. So hopefully, if you recognize that that's an area, if that philosophy or how you embrace failure or don't in your organization, that might be a process redesign you could tackle.
Yeah.
So where do we go from here? How do you take steps towards becoming a learning health system? Well, it's going to take some work. It's going to take intentionally time traveling back to science class. So, okay, tonight, go home, find your tote of high school junk, get the dust off it, open it up, pull out your lab coat. I was telling Travis earlier my lab coat was tie-dyed.
Which is amazing.
So you don't have to have a white lab coat. You can have your lab coat be designed however you would like. Get out that lab coat, put it on, see if it still fits. If not, go buy a new one. And start asking questions. As Josh was just punctuating about the performance or how those companies work, we need to resist our urge to kind of fall into the mentality that our system, I'm a CMHer myself, and I've grown up in that environment, and oftentimes when we're faced with an issue, we think, well, what does DCH say? How are we supposed to do this? Or what's the CARF standard say? Look it up in the CARF manual. Or, gosh, I think there's a compliance measure we should be focusing on, or a plan of correction from a few years ago. We're so in the box and so looking for an answer to be delivered to us, looking for that magical checklist. Please remember the magic behind a learning health system is simply to think critically. Think critically as individuals, as teams, as an organization. But for those of you that are, those type A folks out there, like myself, that want maybe a little more tangible steps out of this webinar than a lab coat guided imagery exercise, here are a few recommendations that come from the Institute of Medicine report, A Best Care at Lower Cost, which, mind you, that's where much of this information was taken from. So if you have more interest in learning health systems, please check out the IOM's information. But to start with, electronic medical record is kind of a muff, right? We really need to be with the times and having an electronic medical record. And if you already have one that you love or hate, I'm sure that there are pieces with that system where you are maybe still just capturing information in long narratives and not discrete data points that can be pulled real time and used to inform managers or team members or patients themselves. Or maybe you're still using hard copy forms. We know that as you adopt a new electronic medical record, you often hear that's a customization, and customization equals $signs. So sometimes it's easier to just use a hard copy form and scan it in, and you've met the DCH requirement or you've met the compliance requirement. But that's not what's going to get you to become a learning health system. So maybe you can find for one of those questions as you're all sitting around your next staff meeting in your lab coats, and you come up with a meaningful question that you want to answer, if a data point that's tied to that question, you're only capturing it in a narrative or hard copy form, that's an awesome opportunity to jump in and figure out how can we start collecting this as discrete data that we can gather in real time. Data systems that share. This is hugely important. Even if you have an excellent electronic medical record and great access to your internal data, how is that helping your consumers if their primary care organization and their primary care provider have no real-time access to that? And vice versa. How are we supposed to embrace our role as care managers and provide integrated care if we have no access to healthcare data? So there's been huge gains in this area with Care Connect 360, with many of the software or data analytic vendors that are out there helping us to look at the big data, but we need to continue to work with health information exchanges and other formats to be able to have all of our data systems talking, much like some of the industries that you mentioned earlier, Travis, like the airlines and the banking systems. And as our quote says at the top of the screen, knowing is not enough, we must apply. Willing is not enough, we must do. You've got to use the data. It's really okay to get into that, or it's really easy to get into that spot where we just think, well, this would be neat to know, or what about this? And gosh, let's look at that. But you've got to use it. Do something. Get your lab coat dirty. Care improvement. As we look at the care we provide, there are a lot of things that can enhance the quality of our care. Now, I'm a social worker by training. Travis, you're a counselor. So I think we can both agree that a lot of our field historically has been based on kind of gut feelings and, well, I just know this because I've worked with this population and this is how I do my thing and it works. And I'm not discrediting that. I mean, there's wonderful clinicians out there making the difference in folks' lives every day. However, as a system, we have a responsibility to incorporate some decision support tools that will help all clinicians to provide care to various populations for certain issues or presenting conditions in a consistent, valid, reliable manner. We, when possible, need to implement evidence-based practice guidelines. There are care guidelines out there for depression. Often, if you go to a CMH and go to the outpatient department and interview 5 therapists on how they treat depression, you're going to get 5 different treatment examples. And some of them may be backed by evidence and support, and some may not. So when possible, not that we need to use a cookie cutter for everyone, but when possible, let's educate ourselves and use evidence-based practice guidelines to provide consistent treatment for various populations. Patient participation, we've talked a lot about that today. Again, we do some good work here with our use with peer supports, our person-centered planning process. I think we have a lot to offer the healthcare system at large with how to include patients in care. Coordination and transition processes. This near and dear to my heart with my belief in the importance of integrated care. Unfortunately, even in small communities, it's like the Grand Canyon between primary care and behavioral hospital. And so there's so much opportunity for us to do better with our shared care of folks, and when folks transition from maybe an acute care setting to an outpatient setting, or from having their psych meds covered at the doctor's office to a psychiatric unit. And finally, community partnerships are critical. If a learning health system is not only communicating and learning within its own walls and communicating within its own system, it is so important to reach out to the hospital system, the primary care system, the local health department, and work collaboratively, maybe even getting to the point where you have data sharing agreements and you can actually have meaningful discussions, including protected health information, with appropriate consents, of course, to look at how to improve care, how to meet the triple aim in your community.
Mm-hmm. And along those lines, I think that you can even branch out of the healthcare industries to say, you know, people who aren't even necessarily receiving Medicaid funding for the services, you know, homeless shelters, missions, other people that serve the same people that we serve. How can we work together? A lot of times you might find that certain organizations aren't necessarily considerate of or aware, educated in trauma-informed practices, in just simple behavioral health care processes, and it's important to serve as an educator when we have the opportunity for our communities, but also to develop those relationships so that we can be the most helpful that we can to the people we serve.
Yeah, absolutely. Trauma-informed system of care is a great area where we can reach out to other community partners to help them. The whole idea of the social determinants of health, there's some great work being done in local communities where healthcare providers are partnering up with agencies like True North that help people meet their basic needs. I'm aware of a project in Nuevo County where the Healthcare Coalition is working with True North for their folks that are getting heat assistance and helping link them with the healthcare services that they need. So instead of going at it from a healthcare provider, they're going at it from the social determinants of health and the other things that people need to have a healthy, high-quality life, and working together.
Mm-hmm.
So think big when you think community partnerships.
Yeah.
And then just to kind of sum up, those other steps are only possible if you have a supportive policy environment. So as we talked about briefly before, the importance of financial incentives. And again, there's a lot of information out there on that. Educate yourself as an organization. Be aware of where your state is headed with funding, how our reimbursement and payment from the state is going to be tied to value in the future. Again, that's going to be phased in over a period of time. But let's look at the areas that are already doing it and start preparing our organizations for that reality. You talked earlier about the importance of transparency, and it's transparency in all of these domains: safety, quality of care, the financial aspects, the outcomes. This should be open and available to providers within your organization, to the people you serve, to your community partners. And of course, we can't reach any of this if our leadership, our leaders at this time are so critically important to set this culture where failure is acceptable, where we're constantly going to be learning and be devoted to continuous improvement, and taking that, having leaders willing to say, put your lab coat on and ask the hard questions. We hope that you have taken away a few good ideas today, if at least just a trip down memory lane to thinking about your science teacher and back to remembering it can be exciting to ask questions. It can be exciting to believe that things can get better, and believing that your organization can become a learning health system is an exciting time. So we wish you luck on that journey. thank you so much for your time today. We hope you all have a wonderful afternoon, and take care.